How's it
How are you
going,
doing?
Travis?
I'm well. Just got back from where's it, Wyoming? You went all the way from Texas all the way up though, right? So you went through
Did.
Colorado, everything.
I did. It was a lot of fun. We drove through West Colorado, up through Pagosa Springs, then Ouray, and then on to Wyoming, Jackson Hole, Wyoming.
You didn't want to keep going and all the way to Canada? Just like
Thought about it. Thought
pop
about
your
it.
head in there, and be like, what's going on in here? What are you guys doing? And then come
Yeah,
back.
I was afraid I might get chased out though.
You might have. That's a good point.
But
All right, let's talk about oh, go ahead.
no. You go ahead. Sorry.
No, I was gonna say let's talk about I think I contacted you last week about talking about Hip FAI with like the show up students, and you were like, well, I'll be gone. So I was like, all right, well, let's do something when you get back. So if you want to maybe start with like what you would look for as a trainer for a Hip FAI, and we'll go through the entire process of like rebuilding somebody back to where they can perform their sport, where they can do their daily activities without pain and being more comfortable. Of course, pain is going to be a multifactorial thing. So it's not like, and the pain, I like to remind some of my clients that the pain is still there because sometimes the brain forgets like to shut that receptor off, right?
Yeah.
So just because you have pain doesn't mean there's like tissue damage or anything. So
Yeah.
anyways, I'm going to turn the time over to you to kind of like what we would look for as personal trainers to kind of like maybe refer out.
So I think the first thing is like symptomatology, or like the symptoms that's going on with the patient or the client. So I mean, the first thing with hip impingement, FAI, what you're going to see is kind of like groin pain. And most of the time it's going to be groin pain with hip flexion based activities. So most of the time when I get a patient or client with FAI, they're kind of getting almost a pinching sensation in the groin when they get down into a full depth squat is the best way to describe it. Now, if you're working with somebody who's maybe like not as active, or they're getting into working out, they might be feeling it going from sitting down to standing, anything like that. So let's kind of talk about like, if it's something that, they're having real, like a lot of pain with real deep, heavy squats, I don't think that it's necessarily something you need to rush out and refer them out for. I think you can start with some modifications to build up some tissue tolerance, because it could just be a tissue tolerance issue. But let's kind of get into the anatomy a little more, because I know that that's something you love as well. And I think that that gives just a good basis for understanding the pathology and what's going on with the hip whenever that happens. So number one, there's two different types of hip impingements you can have. There's a cam impingement and a pincer impingement. Now, cam, and I got to double check, but cam is where you have the head of the femur, and then bone is starting to grow further, kind of wrapping around closer to the head of the femur over that joint surface. So that can cause some of that pinching pain and sensation. And then with pincer, it's the opposite. So where the hip sits in the acetabulum, you have bone growing over to where it's pinching down on that joint surface as well. Now, obviously, both of these are structural issues that a physical therapist or a trainer can't change, but that doesn't mean that that is necessarily the source of the pain or the issue that's causing the pain. So kind of similar to like if somebody has a low back pain and they go get an MRI, MRI is going to show something dysfunctional, whether it's disc degeneration, disc pathology, joint degeneration, anything like that. It doesn't necessarily mean that it needs surgical intervention, just means that it might need some, movement intervention, basically. Do those two things, like, what do you think about those so far?
So what is the cause for the bone growth over the head of the femur? What happens where, like, what's the cause for that? Is that just normal? Like sometimes that happens.
Yeah,
Is
so
there
it's,
any way to prevent it?
I don't know that there's any way to prevent it, because it's not really like arthritis or something where it's bone on bone. I think it's more like looking at someone's hip being anteverted or retroverted. Like some people just have that extra bone growth in that spot. Along like another good example of that is like AC joint abnormalities. Like some people are more predisposed to shoulder impingement because of the way their AC joint is shaped. Similar in the hip with the hip impingement. You have maybe someone who has a little bit of extra bone growth that causes a little increased risk of impingement. And I kind of like to relate it to like cardiac disease, because this is kind of where I put my patient and client's mind at when they come to me with an issue like this. Is yes, there's certain genetic factors that you can't change that are going to make you more predisposed to some issues, but that doesn't mean that there's not, a million movement things that you can work on to help prevent the pain. Similar with like cardiac disease, you might have genetic issues that result in cardiac problems, but there's still healthy diet, exercise, everything like that to help prevent, even though you might be more predisposed to it. Does that make sense?
Mm-hmm. So it's usually somebody that might have already had it and maybe they start activity and then they notice that it's kind of like hitting. And then they're like, why do I have this pain right here? So
Exactly.
it's always been there, but then they don't notice it because they haven't had that activity yet, right? Is that kind of what you're
Correct.
saying?
Yeah.
So
And
as they get more involved in sports or exercise, they notice it more.
yes. And to those people, I usually say, like, hey, if you have this structural abnormality that predisposes you to this type of pain, it doesn't mean that there's not stuff that you can do to prevent the pain. It just means that you have a greater responsibility to, stay focused in on this and work on this to help prevent it. So like you may not have any structural abnormality in your hip. So working on the mobility and everything like that might not yield as good of results as it will for that person, or might not be as important for you. Whereas someone else who might have those abnormalities, they need to do it every day, if that makes sense. Or they might need to do it every day.
So it's like somebody maybe that has a predisposition to like the cardiac stuff that you were talking about. They need to maybe eat more salads and watch their diet more than somebody that can like eat whatever they want, and maybe their genetics can filter that out better. Where
Exactly.
the person with the FAI has to like always do their mobility work, always stay on top of their movement protocols just so that they can stay healthy and not have that issue.
Exactly. That's exactly
Gotcha.
right.
So what happens I guess when so let me rewind. So what happens when the trainer notices it? What are some things that we can do to scale back for our clients to keep them working in the gym, right? Because the last thing we want to do is like refer out and make the client have to pay a bunch of money, and then the physical therapist looks at it and they're like, this is like, you could have just done this, right? So what are like A, B, and C to do before you refer out?
So I think number one, like a mobility screen is necessary. So I think an easy way to do this is just watching their deep squat form. So when they squat, do they get to a certain point where they either have to arch in their back or they have like early butt wink? If they have to arch in their back, that can be indicative of hip flexor involvement, as far as like uh, basically the hip flexor is tight, so it's pulling them into extension and rotation in their back. And then that can lead to that impingement type symptom. And then the other thing, if they have early onset butt wink, where they kind of round out more in their lumbar spine, that usually is indicative that there's a block keeping them from being able to flex their hips as far as they should. So a hip flexion limitation. Both of these are going to be very heavily focused in on hip flexor training, one mobility, the other one strength. And eventually both of those are going to meet in the middle and you're going to be doing both. But with that, also training core stability with their squat, basically, because it all starts at the lumbar spine and hips on how you position that pelvis. Because if they let that low back arch, they're going to, their pelvis is going to tilt forward. That's going to lead to a lot more of that pinching. That makes
So
sense.
if they have an anteriorly tilted pelvis, they're already kind of in a bad position to go down into their squat. and then they don't get as much depth, and they don't have the space. So of course our body's going to create space, which kind of like gets that heavy butt weak, right? Which if your client is just like some just, gen pop person that just wants to look better, butt wink isn't the end of the world. But if it's somebody that is having FAI, that probably could be an issue.
Yeah, and when talking about butt wink, I'm not a big person on like, I think it's the worst thing in the world. But if you're like barely crossing parallel and you're starting to do that already, that's when I'm like, okay, that's an issue. Whereas if you're getting full depth and at the very end you get a little bit, that's not really a problem. It's more just about when it starts and how it starts. I would say though, with 90% of people, given how much we sit, you're going to see more of the arching in the back versus the winking. I think with your higher level people who have been training for longer and who are a little more advanced, you're probably more likely to see that butt wink versus arching in the back. But kind of leading into what your previous question was on like, how do they prevent it? What the recommendation would be is, I think, number one, train them within their tolerance starting out. So let's say you get somebody who comes in and has hip impingement and they feel pain right when they go past parallel with the squat, but they can squat to parallel or 90 degrees without pain. Start them doing box squats at 90 degrees so that you can continue to train within that range while simultaneously working on the other deficits you need to. And then slowly, in kind of a graded exposure manner, start dropping the height of the box a little lower, trying to get them into a full depth squat.
Gotcha. So just gradually exposing them to more loads at a shorter range and then taking that away. So just the gradual exposure method.
And that kind of gets you that tissue tolerance buildup, because sometimes even just the pain comes from a lack of tissue tolerance.
Gotcha. And then, so what happens when it gets so bad that they go to you, right? So we did that screen, I checked it and I was like, you know what? I don't have the resources to help you, but I have a great physical therapist that I network with. His name's Craig. Here's his information, and I send him to you, right? It's so bad that I'm like, listen, I'm not going to mess with it. Let's get you out of pain and get back to work. Here's Craig.
And I think
what do you do?
And I think that's a good point of, and I guess maybe I wasn't clear enough on like when that point is. And I think that point is when people are, having pain with daily activities, going from sitting to standing on, or like going from sitting on the toilet to standing up, and it's just limiting, or like they can't drive without feeling the pain. That's when it's a little more serious that you might need to refer out. But typically when people get to us, the first thing I'm going to look at is anterior chain mobility. So basically hip flexor mobility, quad mobility. And then I'm also going to check how far they can flex the hip. Now, what I'm typically checking for is, number one, there's a certain amount of joint play in the hip. So when you have the head of the femur and the acetabulum, whenever you flex the hip, it needs to glide inferior posterior. And then when you extend the hip, it glides anterior superior. So with today's world, how much we sit, almost everybody has tight hip flexors. Not everybody, but almost everybody. And so typically what that does is that's going to pull the head of the femur forward. So I'm looking to see, is that posterior capsule tight, causing it to shift forward along with the hip flexor? So I'm going to work on, number one, hip flexor mobility. Number two, posterior capsule mobility, so that as they flex the hip, they get more range and they get more free movement, versus that head of the femur butting up against that area that might have structural deficits like we talked about, where the bone and bone hit and cause the pinching. And then we're going to start working on combined movement. So I want to check out how well is their, like how good is their pelvic positioning with squatting? How strong is their core to keep that pelvis in a good position? Because typically those two things go hand in hand. You're not going to see somebody typically with super tight hip flexors without a core deficit, just because over time they learn to adapt to life around them by relying on that hip flexor tightness. for stability in the lumbar spine and hips, if that makes sense.
Mm-hmm. I know like a lot of people. So I had a client that would always, he would say that she kept getting told that she has tight hip flexors, right? And so she would constantly stretch her hip flexors. And I was like, listen, and she was like, this, it hurts so much, you know, like right here. And I was like, all right, stop. Like, I need you to stop stretching them. And I need you to do these exercises to strengthen them, right? So we started strengthening her hip flexors, and that changed almost like within the week to 2 weeks. And she's like, holy cow, my hip pain's completely gone. I don't know what happened. So is there a time where maybe they have tight hip flexors, but could they be weak where they're not working properly?
Yes.
Or and how do you judge between like a weak hip flexor, tight hip flexor? Like where in the area do we look for that?
So, and that's a very good point that I did not touch on, but you're never going to be in a situation, and let's just like kind of simplify it here. You're never going to be in a situation where if there's a tight muscle group, that muscle doesn't also need to be strengthened. Because what we see is, if you're strong in this range, I'm sorry.
No, you're fine.
Oh gosh.
What was her name again?
Pearl.
Pearl's making an appearance.
So
Pearl's like, what if I have tight hip flexors?
Yeah, she definitely has tight hip flexors. But if your hip flexor is strong within this range and you're not doing a lot of like full depth squats or anything like that, then it's going to only be strong in that range. So whenever you go in and you see your trainer and you try and start doing full depth squats, that's where that deficit's going to arise, when you're being pushed outside of what you're, strong within. So you need to tackle the hip flexor mobility, and then you also need to strengthen that hip flexor through the full range immediately following stretching it out, basically.
Okay.
Does that make sense?
So you're saying, yes. So you're saying, make sure I have this right in my head so everybody understands it that's watching still. So we want to strengthen it and then stretch it, is what you're saying?
Stretch it, then strengthen it.
Stretch it and then strengthen it.
You want to take it from this spot where it's strong within this range, and it's like can only move within that range, to where it can move within this range passively, but then you give them active exercises to where they strengthen within that range.
Gotcha.
Because I think, your point is very good of your client who was having hip pain continually, and she was stretching, but she was never doing anything to reinforce the mobility that she had gained. That's where the pain comes in, because you can stretch it out to this point, but then you go and try and move within that point. You don't have the stability to support that new range of motion.
Okay. So we're strengthening through a lengthened range where once we stretch it, that releases kind of like our nerves that are kind of like protecting everything, kind of lengthens everything out, makes them like relaxed, and then start strengthening it through a longer range between the 2 points.
Correct.
Gotcha.
And
all right,
back to your original question, there are times where people come in and they do have good hip flexor mobility, and it is a strength issue purely. And in that situation, obviously, all you would need to do is work on strengthening. And I think that that's a really good pairing with the graded exposure, like we talked about, because as you work on their mobility and their strength in that hip flexor, then you also want to work on functional movement, like a little deeper in the squat, to help reinforce that in a functional manner versus just an isolated manner of just strengthening the hip flexors.
Gotcha. No, completely. So what are like a few exercises that you would do with your clients? I know that there's the ball one that when I was there with you guys, you had somebody on a ball and they were just rolling back and forth slowly, bringing their hip up, and you had a band resisting hip flexion on their foot, right?
Yeah.
So they were. What other ones are fairly that you would maybe progress from like low hanging fruit to like a little bit more complicated?
So I like following kind of a neurodevelopmental timeline basis for progressing clients and patients. So that one that you're describing there, and we're talking from the strengthening standpoint, that one is like level 1. So I'm going to start them with that one where they're on their back and then they're rolling the ball towards them, making sure that they're keeping their core engaged and keeping their lumbar spine in a neutral position. So basically a TA brace with that. Then I'm going to progress them to a seated where they kind of hug the knee to the chest, pull that hip into as much hip flexion as they can. Then they let go and they have to slowly lower the foot down on their own without arching in their back or compensating with their back. It's all coming from the hip. Then after that, I'm going to take them to a half kneeling posture. So they'll be kneeling, engage the core, and then try and march with the opposite leg, march into hip flexion. And with that one, I like to add a TA brace to, like a lat pull down if they can, if they have the balance for it and the stability for it. And then if not, they can hold on to the wall or the couch as long as they're making sure that they maintain that pelvic positioning. Then after that, you can get into standing marches with the TA brace is a really good one, resisted with the band marches. And then one of my favorite ones is a assisted squat. And this one takes a little bit of setup. And so I typically don't do it unless it's a higher level person, but it's really hard to get the hip flexors engaged maximally when they're squatting without this. But what I do is I take like a half foam roller or something, and I put it over their feet and anchor it down with both like a weight on each side. And basically what they have to do, and then I'll hook a band, like a power band around their shoulders that's hooked to the top of the squat rack. And then they have to basically pull through their feet to flex the hips and get themselves down to the ground in a squat. Does that make sense?
Yes, kind of. Yeah.
So it's basically taking it from, like, with a regular squat, the hard work comes from the hip extension when you push up. We're basically reversing that to where the hard work comes from pulling down into the depth of the squat. And then just it on the way up.
Okay. And is that, like, what other exercise? So those are for the hip flexors. What else would you do for somebody that comes in with an FAI? I mean, you did talk about the two different types, so that wouldn't be the only thing that you would do. What other approach would you take for somebody?
Another one that I look at is hip hinging pattern. And that kind of goes along more with what we talked about earlier on about like the butt wink. So if they don't have good spine control, I'm going to work on their hip hinge, maybe even take less focus off of the squat for a while and work on the deadlift to get glute max engaged, get core engaged in that pulling motion. Because some people just, don't have the motor ability to maintain a neutral lumbar and thoracic spine while they squat. And that can result in those hip issues. So doing like a hip hinge pattern with a stick, working your way up to a banded resisted hip hinge pattern, and working your way up to, a Romanian deadlift, hex bar deadlift, traditional deadlift. And I might even take them away from the squat for a little while to work on that stuff, and then slowly reintroduce the squat.
Okay. And then, so how long of a time period is this that you're working with them? Maybe once or twice a week, right? I don't know what your schedule is with people usually.
It just, and
go
that's
ahead.
Sorry.
No, you're good.
I was just going to say that's one of those things that just depends on the client and how active they are. Usually how I like to stack things is, if they come in and they're super flared up, I usually say, hey, let's start the next 2 weeks, twice a week, working on this. And I'm going to do like the manual therapy, dry needling if I need to, joint adjustment if I need to, work on the hip mobility, and then get them out of pain. And then as soon as I can get them out of pain, then I want to dial it way back, because I want to see somebody over the course of, 3-4 months versus burn through all their visits right up front, to where it's like they run out of visits when I've just gotten them out of pain. And I kind of like, that's how I like to structure things. And if I have clients who are working with a personal trainer too, who might have dialed back from working with the personal trainer, I want it to kind of cross over to where, as I'm backing off on my treatment and they're getting more independent with their treatment, I want them ramping up their training with the personal trainer. That way me and the personal trainer can work together to make sure that the client can do everything that they want to do with the personal trainer in the gym without issue, if that makes sense.
For sure. And I guess this is where we cross paths of like bridging that gap that we talked about is what would you prescribe for the personal trainer to start at, right? Because as we know, a lot of personal trainers are not, you take a test and out of a book and then you're going and training grandma and then injuring people, where they don't have the basic concept to meet with a physical therapist to be like, hey, like my person went to you, I'm going to be training them. What do you want me to do with them? Right. What would you suggest for that personal trainer?
So I would suggest the graded exposure aspect. So I would hope that by the time my client's starting to work again with the personal trainer, that I've started that kind of limited depth squat training in clinic. And so I would want them to kind of continue that on. And I would also want them to continue to work on whatever deficits we had, like we talked about, where it's like this person might need to continually work on it versus, they're all on the clear now. But working on hip flexor mobility, keeping some hip flexor strengthening in there, the routine pretty frequently, like enough just to kind of prime the hip flexors before they squat or before they do, their deadlifts, that they're getting that stuff worked on. I don't think, like in talking about bridging the gap, just like you said with personal trainers, a lot of them get it from, an online certification or a book and they're good. They don't necessarily know where they're at. I would say that a big problem that personal trainers are going to run into is they're going to work with a lot of PTs who it's like they've been seeing this person for 4 weeks. They've been doing the same exact crap the entire time. The PT hasn't, gotten them under a bar to squat or hasn't had them do any, functional stuff outside of just a few isolated strengthening exercises or the bike. So if you can work with a PT who has this ideal plan, kind of like you and I have, and the rapport you and I have, that's awesome. But if not, I think that I would challenge more of the personal trainers to unfortunately have to be the one who has to bridge the gap of, okay, you haven't been doing any of this stuff in PT. Let's start this graded exposure squatting. Let's continue to work on the mobility stuff you need to work on and then work our way up. Does that make sense?
It does. And sometimes I forget that you guys have the same problem that personal trainers do, is like, yeah, you went and got a degree, but at the same time, how much did you further your knowledge in like being better? Right.
Yeah.
Where you go to a PT mill and you just prescribe the same exercises off this piece of paper and that's all you do. And then, and the insurance only pays for X amount and you're like, well, see you later. And so it's like, you've been there and now you own a cash-based clinic, which is much better for your clientele. So yeah, sometimes I forget that not all PTs are alike and it's kind of the same thing where it's like, did you actually further your education and get better, or are you just repeating the same stuff that you learned from a textbook that was made years and years ago?
Yeah.
So,
And I think that the biggest thing, like if you're a personal trainer working in an area and you don't know where, like you don't know of any good PTs, the first thing I would try and do is find a fellowship trained PT in manual orthopedics, because usually they're going to have a little higher level of knowledge and a little more motivation than just your regular run-of-the-mill PT. So those are people who I would try and get connected with in your area. And then, like you talk about, is try and get in and shadow them, because they'll have a little more knowledge. And if you can find a cash-based practice, even better. And what I'll say is, even from my perspective, like when I'm working with a client who needs to go see an orthopedic doctor, I've had clients who I've told like, hey, I would go see this orthopedic doctor rather than the orthopedic doctor you're with. And don't be afraid. Like if you have that rapport with your client, don't be afraid to be like, hey, this PT clinic is crap. I would go see this guy over here or this girl over here at this clinic. They'll take better care of you. They're more on the functional side and more on the side of getting you back to what you want to do versus just, running through the same insurance crap all the time.
Yes, and there's a lot of people that maybe, I'm sure you see it all the time, where in the PT mill setting where you treat somebody and then you release them and they don't have a personal trainer to go to. They don't have anybody to go and keep them moving, right? Or they just, I'm sure you see it all the time, they don't do their exercises and they just think you're supposed to fix them. And I'm sure that's extremely frustrating. So I wonder if there's a way that, what's the best way to like contact a fellowship, or how do you look for a fellowship PT?
So actually, and I can send you a link to it through the credentialing board for fellowship PTs. There's a search, like search for a fellow in your area. So I can send you that link. And, you know, that's going to be a better grade of how good PT
I see you
is.
smirking. I see you
But it does,
smirking there.
and I'm not trying to contradict myself here, but like you're more likely to find a good one with fellowship credentials, if that makes sense. It's not a guarantee, but you most likely will find a better one with fellowship credentials, if that makes sense.
Yes, because they maybe are furthering their education rather than somebody that just got out of school and like, yeah.
Let me put it this way. It's like having your doctorate in physical therapy is like having your NASM in personal training, whereas having your fellowship in physical therapy is like going through Show Up Fitness's program.
Yes, that's a good way to put it. So it's like McDonald's compared to like having a nice juicy steak.
Yes, exactly.
Yeah, that's a weird industry. What else, I guess, should we know as far as the FAI? Like, we're closing up, we're done, like our client is here. Is there going to be flare-ups? Are there going to be other issues that we see? Are we going to have to send homework with them, like as personal trainers? Like, because I'm gonna give this class to my students, and so they're going to watch it, and I want them to be fully prepared if they end up having somebody with FAI, that they're like, oh shit, I watched the YouTube video on that, and they know exactly what to do if maybe it flares up, to kind of get them out of how they're feeling.
I think number one, you're going to see a lot of low back pain tied to the FAI because those usually kind of go hand in hand. So if they have a flare up, I mean, I tell people all the time, it's never a linear improvement. Like you never just go straight up. There's going to be ups and downs. And especially as you're going through that graded exposure approach, you might hit a point, like say you've been working on it for 8 weeks, you're getting close to having them in a full depth squat. You might hit that point where you get them in a full depth squat and they have pain and they get a flare up. You just need to back it off a little longer, work at that pain-free range a little longer, and then over time, maybe drop the weight, put them in a full depth position with less weight, kind of work your way up there. I think the biggest thing is educating your client that, there's no 100% perfect fix where you never have pain again. This is always going to be something that you have to be conscious of. This is always going to be something that we got to work on. So I definitely think sending them with homework is a good idea. And then also lifestyle modification. So like we talked about with a lot of people who we all sit all the damn time now, like we sit all the time. And so coaching people on like if they're working a desk job, hey, get up every 10 minutes, walk around, try and stretch out the hip flexors versus just kind of being in the sitting position for 8 hours straight. Because we get in our car, we drive to work, we sit at work, we drive home from work, we sit on the couch, like encouraging them basically just to incorporate more standing activities in their day. And then obviously sending them home with hip flexor mobility stuff, the hip flexor strengthening, like you're talking about, and the core strengthening. If I had to break it down into the 3 things, that's what it would be: is core strengthening, hip flexor mobility, and hip flexor strengthening.
Sweet. I think we kind of covered the whole thing. So anything else you want to add to it, or is that it?
I think that's it. But I just, another word of encouragement is y'all can do a lot of good damage in a good way of preventing people from getting trapped in the healthcare system, going to get unnecessary imaging and everything like that. If it's just kind of a pain that's with squatting, continue to work through it with the graded exposure approach, hip flexor mobility, everything like that. If it develops into a painful situation where they can't, do their day-to-day stuff, definitely refer them to a PT or an ortho. If they start to develop, radiating symptoms down into the feet or down the leg, definitely refer them out. But I think if it's just a movement related kind of deep squat thing, you can help them prevent it from getting any worse, if that makes sense, or help them from having to go into that, situation. What was that thumb? That was wild.
I don't know. I have no idea what that thumb was. I was like, what the heck? Was it like I don't know.
Yeah, are we getting hacked by China?
I don't know. It's just you and me on here. That's crazy. I have no idea. I know there's like a new AI thing where it's like signals. I don't know. I have no idea. That's weird. Well, that's a good way to.
Right.
Well, I'm going to stop recording that because that's weird.
It's very weird.
All right. So everybody go find a fellow. I will get you guys that link to find a fellow to work with. Of course, use discretion as well, like we talked about. But thanks for showing up, everybody.